Hello, welcome to today's episode of the Clinical Care Options podcast series, A Bold Panoramic Grasp of Tardive Dyskinesia. I'm Dr. Deanna Perkins, Professor of Psychiatry at the University of North Carolina at Chapel Hill. Here with me today is Dr. Rajiv Tandon, Emeritus Professor of Psychiatry at Western Michigan University Homer Stryker MD School of Medicine. Today, we will be discussing the available management options for tardive dyskinesia. And in addition to discussing specific management options, we hope to provide you with some clinical considerations for individualizing treatment. So Dr. Tandon, let's get started. We've known that antipsychotic-induced tardive dyskinesia is an adverse event since the 1950s, but until 2017, there were no FDA-approved treatments. So what are these FDA-approved medications for TD?
Well, Deanna, it's a pleasure working with you and sharing our thoughts together on the newer treatments for tardive dyskinesia. Well, not that new now, because they've been around since 2017, past 5 years. But we've been dealing with tardive dyskinesia for 60 plus years since antipsychotics were first utilized in the 1950s. And until 2017, we had no approved treatments. The first approved treatment for tardive dyskinesia was actually April of 2017, valbenazine. And later in August that year, butetrabenazine was also approved for the treatment of tardive dyskinesia. Now, both these agents are basically developments on a relatively old compound, tetrabenazine. As we know, reserpine actually, for those who want to go back in history, reserpine was the first drug treatment for schizophrenia, even before chlorpromazine. Bose in 1940 basically introduced it to treat psychosis. But reserpine, like tetrabenazine, belongs to a class of medications called VMAT inhibitors, or vesicular monoamine transporter inhibitors. Now, these, as we know, for neurotransmission to occur, there has to be the neurotransmitter in the presynaptic site that's going to release the neurotransmitter. Now, in the cytoplasm, there is monoamine oxidase, an enzyme that metabolizes, that would destroy the neurotransmitter, which is why the neurotransmitter has to be stored in vesicles. And the vesicular monoamine transporter essentially arranges the movement of the neurotransmitter once it's synthesized into these vesicles in which it's stored. Now, what the VMAT inhibitor, like reserpine or tetrabenazine, do is that they basically prevent this from happening. So the neurotransmitter stays in the presynaptic neuron and is metabolized. So once the presynaptic neuron wants to send a message, there is very little neurotransmitter to be released. So in effect, it's depleting the presynaptic vesicle, the presynaptic neuron of the neurotransmitter. Now, obviously, the other way to reduce transmission at that site is to block the receptor on the postsynaptic site, and so that you can block neurotransmission that way. But this is another mechanism of inhibiting neurotransmission. Now, reserpine is a non-selective VMAT inhibitor. There are two kinds of vesicular monoamine transporters, VMAT1 and 2. VMAT1 is there in the periphery as also in the central nervous system, but VMAT2 is selective to the central nervous system. Since reserpine is non-selective, if you use it for any central purpose, it's going to cause a whole slew of side effects. Now, tetrabenazine is a selective VMAT2 inhibitor. And so it's potentially useful for depleting the central nervous system of the neurotransmitter, if you will. But it has a very short half-life, because of which it causes a whole range of side effects. Tetrabenazine's been available for the past 70 years. It was approved in the UK and many other countries for the treatment of Huntington's chorea in the 1970s. but the FDA only approved it for treatment of Huntington's chorea in 2008. So, which is why I used to send some of my patients to Canada to get tetrabenazine in the event of very severe TD that needed treatment. In any event, the developments were valbenazine and deutetrabenazine, which basically are developments on tetrabenazine. They utilize its effects, but significantly lengthen the half-life of the medication. Valbenazine basically is a prodrug, which is metabolized to one of the active metabolites of tetrabenazine, and it has a half-life of almost 22 hours. Deutetrabenazine substitutes hydrogen with deuterium or heavy hydrogen, and thereby slows down the metabolism of the medication, and that thereby extends its half-life. These are the two medications, and they have significantly revolutionized treatments for tardive dyskinesia. I'm just wondering what your experience has been using these medications.
Yeah, so I've been impressed with how well they work. Both medications can be remarkably effective in reducing symptoms of tardive dyskinesia, but I also I also understand that they don't just affect dopamine availability. I know as you were talking, I know we think that tardive dyskinesia may be related to hypersensitivity of these dopamine receptors. And that's sort of the reason why we may want to deplete the availability of dopamine for the receptors. However, they don't just deplete dopamine. It's major effects on dopamine, but it also can affect serotonin and norepinephrine. And that may explain some of the side effects that we can see with these VMAT2 inhibitors. So I think that's just something important to remember. It's not exclusively the dopamine system that's being affected, but also other monoamines.
Absolutely. I think it's important to keep just the name in mind. It's vesicular monoamine transporter inhibitor. It's not dopamine vesicle transporter inhibitor. I mean, so norepinephrine and serotonin are also affected, which is why I think, the fact that it's VMAT2 selective at least eliminates the peripheral side effects that could be caused and that are caused by reserpine, for example. The other thing to keep in mind, as you were discussing, the fact that they affect serotonin, norepinephrine, and dopamine in terms of depletion, it's important to keep in mind, I think, that tetrabenazine, because of the fact that it has a short half-life, also has a much higher Cmax. So basically, you get a high levels, low levels, high levels, low levels with tetrabenazine, because of which you get a variety of side effects, which you are much less likely to see both with valbenazine and deutetrabenazine. And I think that's an important distinction that people need to keep in mind as to why tetrabenazine's been available for 60, 70 years. And only now, 5 years ago, we got these two new compounds, which are clearly effective for the treatment of tardive dyskinesia.
All right, that on-off phenomenon is really really important to understand. That there's trouble tolerating tetrabenazine because of its short half-life. So the lengthened half-life is very important, but it also is something that clinicians need to be aware of because of the drug metabolism. Deutetrabenazine is a CYP2D6 drug, and so we do have to be aware of drug interactions, and that's something for clinicians to keep in mind. And I think valbenazine is also a 3A4, but that metabolite is a CYP2D6. So they were designed to have longer half-lives related to their liver metabolism, but we do have to be very careful with these drugs in terms of drug interactions and other drugs that are being prescribed and adjust the doses accordingly.
Well, talking about deutetrabenazine, for starters, a flexible dose trial, a fixed dose trial, ranging from 12 to 48 milligrams per day in two divided doses, whenever you go beyond 12 milligrams per day. And both found it to be effective in the treatment of tardive dyskinesia. Interestingly, when one looks at the minimally clinically important change, if you will, where patients notice a significant difference and clinicians notice a significant difference, that usually translates to a reduction in AIM scores of about 2 or more, if you will. And in these trials with deutetrabenazine, the reduction was about 3 points on average, if you will. 24 to 48 milligrams is the recommended dosage now. And you start off at 12 milligrams per day, and then you go up. You can go up maximum 6 milligrams a day, if you will. I think it's available in 6, 9, and 12 milligram dose forms. And you can go up to 48 milligrams per day. Although typically I have gone up, I usually almost always go up to about 36 milligrams per day and sometimes to 48. How about you?
I think that the same. And I'm of course titrating on symptom response. We can see responses within the first week, but we really do want to optimize the clinical response to the drug, because there is a dose response relationship. Patients can do better on higher doses. So you're always balancing the tolerability, the subjective tolerability, especially with some of the side effects that patients may just have trouble, annoying side effects, but they can impact a patient's willingness to go up. So things like fatigue, sedation, trouble sleeping, restlessness, like those are the rate limiting side effects. So titrating up for tolerability, but really trying to optimize those outcomes, because I've seen tardive dyskinesia go into remission. And that's what I hope to achieve with patients. So yeah, right. There is a balance, but it is great that you do see responses pretty soon after initiating treatment.
Well, with valbenazine, again, the trials were very were clearly illustrated its effectiveness of both the Connect 2 and the Connect 3 trials, and now the Connect 4, the long-term study, if you will. And with valbenazine, you just have to dose once a day. And with deutetrabenazine, the other thing to keep in mind, I think, is you should give it with food. It doesn't have to be a huge calorie intake along with it, about 300 calories or so, with food. With valbenazine, you don't have to. You can give it with or without food. It is not affected by a food. Usually, I start at 40 milligrams per day, and if tolerated, I almost always go up to 80 milligrams per day in week 2. And my experience, and also based on data, if you will, is that it's more effective although some patients do respond at 40 milligrams per day, the response is better at 80 milligrams per day. And, the number needed to treat, for example, i.e. how many patients do you need to treat with this medication for one patient to show clear benefit? The NNT for deutetrabenazine across its doses was about 7, I think. And for valbenazine, for the 40 milligram dose was 7 again, but for the 80 milligram dose was 4, i.e. you have to treat 4 patients to see benefit in one, which is one of the reasons I go up to 80 milligrams per day, for most of my patients. But again, as you know, it's a critical thing to see if it's well tolerated. And so tolerability is important, but you really want to achieve good effectiveness.
Absolutely. And in the long-term clinical trials, there were continued improvements even over the course of a year. So, we can hope to see that. And I know that's so important when we're counseling patients about what to expect with how these drugs are going to work, that the idea that we should see some initial improvements, but that over time, these improvements should continue and we'll know how well it will work optimally if we give this medicine a chance.
When you're starting a patient either on valbenazine or deutetrabenazine, Deanna, what tests, what studies do you almost routinely do?
Well, so beyond sort of routine studies to understand liver function, because these are liver metabolized, we want to make sure that the liver is working well. I also do like to get a EKG. There is a risk of QT prolongation, especially if they're taking other medications that prolong the QTC level. And so we do want to make sure we kind of understand where a person's baseline is. And it's one of the other things that I counsel patients about when we're starting this medication is just be careful about drug interactions. Ask your pharmacist before taking any over-the-counter medicines, or even if there's a prescribed medicine, to make sure that there aren't any interactions with these, because they're safe medicines. In general, very well tolerated, but that the risk of that QTC prolongation, especially with other drugs, is something that I want patients to be aware of, and I do want to have a baseline. I know some clinicians will consider a second EKG when there's a dose increase, before the drug and then after the drug started, and then with dose increases. So I'm, depending on the age of the person and their comorbid medical conditions, I'm more or less concerned with follow-up EKGs, but I'm not sure how do you approach that issue?
Again, like you, I would routinely get a liver function test. I get a CBC. That's a routine thing. But the liver function test is important. And certainly, as you mentioned, a complete list of everything that the patient is taking, all the medications the patient is taking, because there are a number of drug interactions to be aware of. I mean, certainly you don't take it with a monoamine oxidase inhibitor, for example. You don't take both deutetrabenazine and valbenazine together, for example. If you've got a 2D6 inhibitor, like many of the SSRIs, fluoxetine, etc., you really want to make sure you don't go to the higher doses, if you will. You might want to use lower doses. And then with valbenazine, any medication that affects the 3A4 is something you want to take a closer look at. If it's a 3A4 inhibitor, you want to use lower doses, but you can use valbenazine. But if you're looking at a 3A4 inducer, then in that case, you probably may want to avoid valbenazine or discontinue the inducer, if you will, just because of the way the thing is metabolized. So I get a routine EKG at the outset because of the issue of QTC prolongation. But unless clinically indicated, I don't usually get a follow-up EKG.
I do want to go back to the studies that we need to do, because I don't want us to forget the importance of measurement when we're assessing the severity of these symptoms. And so in addition to the laboratory studies, we should do an AIMS, right? It's one of these things that's straightforward to do, and we should be monitoring improvement with the AIMS over time. So I think that we can't forget that. And because there is this black box warning about suicidality, it really does behoove us to make sure that in our psychiatric evaluation, we assess for suicidal thoughts, that we know the person's baseline level of suicidal thoughts, and discuss with them have them be aware that this is very rare, but if it occurs, it is something we need to know about right away. And develop a plan around depression and suicidality from the get-go, because it's something that, of course, is again, it is rare but so serious.
Absolutely. No, I think that's a critical point to note. I mean, obviously, you must do a structured movement disorder assessment, AIMS, prior to starting either of the two medications, valbenazine or deutetrabenazine. And I would repeat the structured measurement at least every 6 months, if you will. Again, you can use less structured measures, over that period. But I would repeat it every 6 months. I think the important thing about the black box warning that you mentioned, Deanna, about suicidality and depression, which are side effects noted on that black box warning. If one looks at the data, those were much more prominent. Those were noted in patients with Huntington's chorea treated with these medications, particularly with deutetrabenazine, which was approved first for Huntington's chorea. Much less, the signal was much weaker or absent, actually, in patients with tardive dyskinesia. Having said that, there is that black box warning, and it behooves one to kind of monitor patients for that, obviously. What about insurance? I mean, have you had challenges with coverage?
Right. So unfortunately, I have seen challenges with insurance coverage. I'm actually grateful that the manufacturers of these drugs do offer fairly generous patient assistance programs. And so that may be a way to increase affordability for patients where there isn't insurance coverage or where there's very high copays. Those are the two issues that I have run into. But I do like to work with patients around trying to find ways that they can afford medications that I think clearly have some advantages over the generic tetrabenazine in terms of frequency of dosing and the on-off issues that we've been talking about. So I think in my experience, generally these can be managed, albeit these are expensive medications. However, tardive dyskinesia is an expensive problem for patients. Absolutely. And so we need to balance those two issues.
And potentially a life-threatening one as well. I've been actually impressed that insurance companies over time have been more willing to cover these medications. Initially, it was very, very, very difficult. But my experience has been better more lately. I believe on average, about more than 50% of the Medicare programs cover valbenazine, and almost 70% of the Medicare programs cover deutetrabenazine, and a number of private insurers are also covering these medications. Now, on the downside, they are almost always they're at tier 5, which involve the highest amount of copays, as you mentioned. And so they're tier 5 coverage, and there is a prior authorization process that all insurance companies require, which is somewhat onerous, but I think worth it, as you point out, because tardive dyskinesia is a serious problem, which significantly impacts the lives of patients and is potentially life-threatening. And these medications do make a huge difference, if you will. And the manufacturers do have programs to support patients, patient assistance programs, and also with copays. And copays can be significant, if you will, $100 plus, if you will. And so there are ways of reducing out-of-pocket expenses, and the manufacturer assistance programs do help.
Yeah, absolutely. It's something that I've learned with several medicines, including these, to inquire about with patients about issues of copay, and to remind them that if that's a barrier, to please try and make use of these resources, or they may have other resources to help them with the copays, but to check into whether or not they can access some of these patient assistance programs.
On the positive side, and you must have had the same experience, Diana, it's wonderful seeing how patients do once they are on these medications and the difference it makes in their lives.
Well, yeah, this tardive dyskinesia, and I know this has been covered on other podcasts in this series, but tardive dyskinesia has so many negative consequences for individuals who are experiencing it, both the stigma, the social consequences, and it can be as well as just the physical consequences, the impact it has on function, activity of daily living, especially when people are more severely affected. So absolutely, it's where I do want to go to bat for patients and really work with them, because it can make such a difference in their quality of life. So I think it is worth it to address barriers to accessing treatment, and especially around the insurance companies. And you can go to bat for patients, and I'm of course willing to do that for folks, especially where the medication has good efficacy. When I was learning about treatment of tardive dyskinesia, there were all kinds of medications that were recommended to give a try, including anticholinergics. And so I wonder about which we've now learned is perhaps not may actually make things worse, not better. Are there other kind of off-label treatments that you know about that should be avoided or that may be helpful?
I think again. There was a lot of excitement about vitamin E, about a whole range of different treatments, if you will, which did not really pan out. Some of the treatments that I do consider, clozapine itself is a very effective agent. All the other antipsychotics, there are varying degrees of risk. Certainly, avoidance of tardive dyskinesia is something that's important, or reducing the likelihood by judicious use of antipsychotics. Certainly, second-generation antipsychotics, atypical agents, are less likely to cause tardive dyskinesia than typical agents, but there is a risk of tardive dyskinesia associated also with the atypical agents. Now, clonazepam, a benzodiazepine, is another agent that I have found has some effectiveness, if you will, in some patients. And so that is one of the agents that I do tend to utilize in addition, or to treat TD in case these other medications are not available or partly effective, if you will. So that's one of the agents that I tend to utilize. Amantadine, ginkgo biloba have some data, soft data. But the other thing that I do is if it's really, really severe, then in that case, if it's a focal dystonia, then I might think about, essentially using agents such as, botulinum injections or something of that sort. If it's tardive dystonia, that's the case, and that's important to think about tardive dyskinesia as being a family of syndromes, if you will. A tardive syndrome, if you will. Akathisia would respond differently than other kinds of tardive syndromes. For example, if it's tardive dystonia, that is where anticholinergics have some benefit, if you will. Clozapine and but only for tardive dystonia. Otherwise, as you pointed out, it would make things worse. And if it's particularly disabling, I would even consider ECT. Now, deep brain stimulation is considered. I mean, it's rarely available, if you will. But ECT is something that I do utilize for severely disabling tardive dyskinesia. How about you?
So before the availability of these VMAT2 inhibitors, I would try lots of different things. And I think you're listing, some of the more desperate measures like the ECT. But since the advent of these VMAT2 inhibitors, I really think they didn't really work well. ECT can be a short-term treatment, but long-term, right, it doesn't work and it's hard to tolerate. So I think those were the approaches that we had such a limited set of tools in our toolbox until recently. And so I tried lots of things. None of them worked very well. Benzodiazepines, I think, reduce, at least my clinical read was that they reduced anxiety. And we do know that TD symptoms vary. And then when people are stressed or anxious, they'll be more severe. When they're less stressed, they'll be less severe. So they just vary according to stress level. And so benzodiazepines, I think, can help in that way, and maybe other ways. I do treat people early on in the course of schizophrenia. And I will see kind of the emergence of very, very mild dyskinetic movements. And one of the first things I will try is antioxidants like N-acetylcysteine or omega-3 fatty acids, maybe high-dose melatonin. And beyond the dopamine hypersensitivity theory, there is some evidence that tardive dyskinesia is related to oxidative stress and oxidative damage. This dorsal striatum is very metabolically active. There's a lot of free radicals, so it's plausible. And so I think that, and there's been small clinical trials suggesting, especially omega-3 fatty acids, maybe high dose melatonin might be helpful. There's been case reports of N-acetylcysteine being helpful, but again, we're talking here not in the very earliest stages or when people are not severely affected. By the time they have AIM scores, right, or that are around 3, I've not found those sorts of management strategies to make much difference at all.
And those antioxidant strategies are too well tolerated. I mean, and so I think, certainly worth trying. Although the data, there need to be more data in terms of exactly how effective and when they are, if you will. And I agree with you in terms of since the introduction of deutetrabenazine and valbenazine, I probably used ECT in one patient, with very severe tardive dyskinesia. The usage has gone down of those kind of treatments. Now, when you start patients on these medications, are there any particularly concerning side effects that you ask them to watch for and call you right away? That, hey, if you have any of these, I want you to call me right away.
Well, so I generally let people know about kind of the annoying side effects. You can see, for example, nausea. You can see agitation. You can see insomnia. These have been reported, and so anything that's particularly that's annoying the patient or is affecting tolerability, I'll ask them to call me on. But I definitely do want to warn them about that black box suicide and to have them call me if that happens. I haven't seen it happen. I think your explanation was good about why that could be, and that this was certainly something that was seen in tetrabenazine and Huntington's disease, and so that black box carried forward. It's not something that's really been associated, but with these newer drugs, but still, that in my mind is the most important safety concern. And otherwise they know what to expect, and that we'll be working together to try and find a dose that's tolerated and is helpful. So, but beyond that, and warning them about drug interactions, and that they should be discussing with their pharmacist or the other prescribing doctor that they're on this other medication, because we do know that at higher doses, if there's effects on metabolism of these drugs at high levels, increase that QTC prolongation. So there's 2 serious things that I worry about that are rare, but people need to be aware of. And other than that, no, it's pretty well tolerated. And so it's only if they're running into issues with, I just can't, it's making me too sleepy, I don't want to take it kind of thing. There's not very much. What else do you warn patients about?
All the things that you mentioned, Diana, and the other things I do caution them about is ultimately this is a dopamine depleting drug. And so, the effects of reducing dopamine transmission, such as you can get akathisia, you can get some worsening of Parkinson's, you can get, and if you get, say, clumsiness or unsteadiness or restlessness, can't sit still, drooling, if you have any of those experiences, I want you to call me. If you have a trembling, for example, like a Parkinsonian tremor, or if you have trouble walking, I want you to call me. And the other thing that I do caution them about is the rare but important side effect of allergy. If you have hives or if you have itching, if you develop welts, or if you've got a red skin rash, things of that sort, any of that happens, I want you to call me, because it's rare, but you can get that kind of reaction, in which case I want to be informed. But otherwise, as you point out, these are very well tolerated medications.
I want to thank you very much for this conversation, Dr. Tandon. I've learned something as always, and enjoyed it very much. And I also want to thank the listeners for their attention. We hope you have found this discussion informative for your clinical practice. And if you'd like more information on this series, please visit the show notes. Thank you.